a 28-year-old female with a history of precocious puberty and irregular café-au-lait spots presence with pelvic pain. I am showing you an AP pelvis radiograph, coronal T1 and STIR pelvic magnetic resonance images, and axial pelvic and coronal facial computed tomography scans. Please describe the findings.
The pelvic radiograph and computed tomography scan demonstrate multiple expansal, lytic intramedullary lesions with a ground glass matrix and sclerotic margins involving the femur and ilium. The magnetic resonance images show these lesions have T1 isointensity and STIR hyperintensity, while the facial computed tomography shows expansion of the facial bones.
What is the primary diagnosis?
The constellation of polyostotic fibrous dysplasia, sexual precocity, and café-au-lait skin spots is diagnostic of McCune-Albright syndrome.
What is the genetic basis of McCune-Albright syndrome, and does it represent an inherited disorder?
It is a non-inherited post-zygotic mutation in the GNAS1 gene. This leads to mosaic somatic activation of the G protein CAMP signaling pathway, causing autonomous endocrine hyperactivity and fibrous dysplasia.
How do the café-au-lait spots in McCune-Albright syndrome typically differ from those in neurofibromatosis type 1?
In McCune-Albright, the café-au-lait spots are fewer, larger, and have highly irregular margins resembling the coast of Maine. In neurofibromatosis, they are more numerous, smaller, and have smooth margins resembling the coast of California.
Which bones are most commonly involved in the polyostotic form of fibrous dysplasia? And how does the rate of facial bone involvement compare to the monostotic form?
The skull, facial bones, pelvis, femur, and tibia are most commonly involved. Facial bone involvement is much more common in polyostotic disease, occurring in 50% of cases compared to only 10 to 25% in monostotic disease.
What physiological factors can reactivate or worsen fibrous dysplasia lesions after skeletal maturity?
Lesions can be reactivated by high estrogen states, such as during pregnancy or estrogen replacement therapy, which can lead to increased pain and enlargement of the bone lesions.
What is the differential diagnosis for polyostotic, expansal, lytic bone lesions with a ground glass appearance?
Differentials include Jaffe-Campanacci syndrome, neurofibromatosis, and osteolytic metastases. However, Jaffe-Campanacci lesions are non-ossifying fibromas without ground glass matrix, and metastases typically affect older patients and lack sclerotic borders.
Finally, what are your clinical management recommendations?
I recommend referral to endocrinology for endocrine evaluation and to orthopedics. Treatment includes bisphosphonate therapy to manage bone pain, and surgical stabilization if there is a high risk of pathologic fracture or progressive deformity.